All right, so now we're going to move into blood typing. So a little mention here, blood transfusions in humans were risky until the discovery of the major human blood groups by Karl Landsteiner, an Austrian biologist and physician in the 1900s, or in 1900. Until that point, physicians didn't understand that death sometimes followed these blood transfusions because the donor blood infused into the patient was incompatible. So blood groups are determined by the presence or absence, of specific marker molecules on the plasma membranes of the erythrocytes. So with their discovery, it became possible to match these things up so that people did not pass on just because they were trying to actually get healthy. So let's take a look at these things. So antigens are substances that the body does not recognize as belonging to the self. So in immunity, which we'll talk about later on in the semester, we're going to talk a lot more about self and non-self, but all of our body cells have these little markers on them called antigens, all of these little markers on them that either say this is self or this is non-self. So all of our body cells that are supposed to be in there, our tissue cells, our heart cells, our liver cells, our digestive system cells, all of these cells have these little markers that say this is self, so that when our white blood cells are going around and trying to figure out if we're healthy or not, or if we need to take care of any pathogens or invaders, that our body cells are saying, nope, I'm self, so we're okay here. And then anything that does get into the body will not have those markers that say I'm self, so then our white blood cells, for example, will go in and can attack it because it's saying, hey, they're not saying I'm self, I'm self. So antigens are substances that the body does not recognize as belonging to self. So this would be the situation that's going to trigger a defensive response from the white blood cells in the immune system. Okay, and again, we're going to talk more about this in immunity, but here we're going to focus on immunity in the blood. Okay, so with red blood cells in particular, you may see the antigens referred to as isoantigens or agglutinogens, surface antigens, and the antibodies referred to as isoantibodies or agglutinins. Okay, so we'll use antigens and antibodies, but just so you know, if you see maybe in the laboratory or other places, a lot of times the term agglutinins is used. I think that's also helpful when we're actually doing blood typing, because agglutination right here, which we'll get to in just a moment, but is this clumping up of this process of blood typing. You can see it clumping up, and it agglutinates. And if you think about it, referring to the antibodies are agglutinins. But anyway, we'll talk about antigens and antibodies. So antigens are generally large proteins, but may include other classes of organic molecules, so including some carbohydrates, some lipids, some nucleic acids. Generally, though, we're talking about large proteins. Following an infusion of incompatible blood, the erythrocytes with foreign antigens appear in the bloodstream and trigger an immune response. So remember, antigen are not self. So if we have blood that's put into our bloodstream that has an antigen on it, right, then it's incompatible. It's saying not self. It's going to be in the bloodstream. It's going to trigger that immune response. The white blood cells are going to say, hey, I found some cells that don't say self on them, and then it's going to attack them. Proteins called antibodies, also called immunoglobulins, which are produced by certain B lymphocytes called plasma cells. We've already talked about antibodies and immunoglobulins, attach to the antigens on the plasma membranes of the infused erythrocytes and cause them to adhere to one another. Okay, so we have these proteins that are antibodies or immunoglobulins. Remember, those are produced by the B cells, B lymphocytes called plasma cells. They are released into the bloodstream and they attach to the antigens, non-self, on the plasma membranes of these infused erythrocytes for this example. And then they cause them to adhere to one another. So we see here, so because of the arms of the Y-shaped antibodies, so antibodies that are released, remember we make the antibodies, the proteins that are floating around, They're Y-shaped, and they attach randomly to more than one non-self red blood cell surface. So I think there's a picture in just a moment we'll look at. Then they form clumps of these red blood cells. So they'll clump up because the Ys, those little Ys, the antibodies, are grabbing onto more than one blood cell at a time. And so then as they're grabbing onto these blood cells, they cause these clumps to form. And this process is called agglutination. So this is that clumping that I was talking about. The agglutination is where it's all clumping together. So the clumps of erythrocytes block small blood vessels throughout the body, and then it deprives the tissues of oxygen and nutrients. So this clumping not only then is the person that has this happen not getting useful red blood cells, then it's also causing this clumping that then can block blood vessels and cause serious issues. So as the erythrocyte clumps are degraded then, in the process called hemolysis or hemolysis, their hemoglobin is released into the bloodstream, and then this hemoglobin travels to the kidneys, which are responsible for the filtration of the blood. However, the load of hemoglobin released can overwhelm the kidney's capacity to clear it, and then you can have kidney failure. So multiple things happen here. If someone is transfused with blood that does not match, then we see these antibodies are going to stick to all of these things that don't match, clump them up. So one, the person's not getting the red blood cells they need to get oxygen to the tissues. Two, we see these clumps of red blood cells that are going to get stuck in blood vessels and decrease the oxygen getting to the area and nutrients. And then three, we have hemolysis or hemolysis, which as this is going through and things lyse, it's breaking apart all of these blood cells, then it's releasing the hemoglobin. As the hemoglobin is released, it overwhelms the kidneys, and then you get kidney failure. More than 50 antigens have been identified on erythrocyte membranes, but the most significant ones are classified into this ABO blood group and the RH blood group. So we're going to talk about those specifically right now. So our ABO blood group, even though it consists of 3 letters, as it mentions here, it's actually just 2 antigens on the surface, so A and B, right here. Both are glycoproteins, glyco meaning sugar, protein, carbohydrate and protein. So people whose erythrocytes have A antigens on their erythrocyte membrane surfaces are designated as blood type A. So if you have the A antigen, that's blood type A. Those whose erythrocytes have the B antigens are blood type B. People can also have both A and B antigens on their erythrocytes. So we have blood type A, blood type B, and then we have blood type AB if they have both. So blood type AB. People with neither A nor B antigens are blood type O. And then these are genetically determined. So we have blood type A, we have blood type B, we have blood type AB, and then we have blood type O, which has neither. So normally, the body must be exposed to a foreign antigen before an antibody can be produced. And again, we'll talk a lot more about that in the immune system, but once the body is exposed to an antigen, then our body will produce antibodies to go fight those antigens. However, in the blood group, in the ABO blood group, that's not the case. We automatically have them in our bodies. So individuals with type A blood, without any exposure to any other incompatible blood, any other antigen that is not self, will have preformed antibodies to the B antigen in their blood plasma. So if you are an A type, you have A antigens on your blood cells, and in your blood serum, in your blood plasma, you have antibodies that are for the B antigen. These antibodies, referred to as anti-B antibodies, will cause agglutination and hemolysis if they encounter any red blood cells with B antigens. Similarly, an individual with type B blood, so B antigens on your blood cells floating around, that's yourself, has preformed anti-A antibodies. So if individual gets A blood in them, then we'll have agglutination. Individuals with type AB blood, then have both antigens, both A and B. They do not have any preformed antibodies to either of them. So they have both A and B on the blood cells, therefore they can't have any preformed antibodies. People with type O blood don't have any antigens on their blood cells, right? There's no A or B, but they have both anti-A and anti-B antibodies in their blood plasma. So if they get A blood, it agglutinates. If they get B blood, it agglutinates. If they get AB blood, it agglutinates. All right, so let's scroll down just a moment. I'd like to go to, before we talk about RH, I guess it's at the very end here. All right, just really quick, I'd like to scroll to this figure 18.7. So here we are. Here's our blood type. If you're blood type A, red blood cell type, you have these, they've put them as little circles. Here is the A antigen on the surface of the blood. Then the antibodies that are in the plasma are going to be anti-B. So then in B blood, we have these, right, kind of squares to show difference. Antigens on the surface of the cell. Then the antibodies in the plasma are going to be anti-A. In AB, we have both A, which are the round ones, and B. So then the antibodies in the plasma, there are none. And then in a type O person, there aren't any on the surface. You don't see any of the circles or the squares. And then the antibodies in the plasma are anti-A and anti-B. Okay, and then we're going to look at this next chunk in just a moment here. All right, so we're going to scroll up to and talk about the RH factor. All right, so then we have the RH blood groups. So we talked about ABO, right? So which is A antigen, B antigen, AB antigen, and then O, which is no antigen. Now we're going to talk a moment about the RH factor. So then we have the RH blood group. So this is actually the presence or absence of antigen RH. So RH blood group, according to the presence or absence of a second erythrocyte antigen identified as RH. They also call this D for shorthand. So it's either RH or D, which I think it mentions it here in a moment. So it was discovered in rhesus macaques. So it's the RH for that. Although dozens of RH antigens have been identified, only one, here it is, designated as D, is clinically important. So we want to know the D one. So it's either RH sometimes or it's written as D sometimes. Those who lack it, so actually let me back up here. So those who have the RH D antigen present on their red blood cells, on their erythrocytes, which is about 85% of Americans, are described as RH positive. Those who lack it then are RH negative. So here's a note that RH is distinct from the ABO group. Okay, so it's not related to whether you have A blood, B blood, AB blood, or O blood. RH positive, RH negative is not related. So it doesn't matter the blood type. When identifying patient's blood type, then the RH group is designated by adding the word positive or negative to the ABO blood type. So perhaps you've heard of that before. So for example, A positive, so A positive would mean that they have A blood, so the A antigens on their blood, and then they have the RH antigen is present. So they also have the RH antigen on their blood cells. For example, AB negative would mean that they have AB blood, A antigens, B antigens, and then they do not have the RH antigen. Okay, this chart here is the summary of the different blood types within the United States. It's not necessary that you know that breakdown, so it's just kind of interesting information. All right, so in contrast to the ABO group antibodies, which are preformed, so remember we have preformed antibodies floating around that are for the opposite antigen. Antibodies to the RH antigen are produced only in an RH negative individual after exposure to the antigen. Okay, so this process is called sensitization, and it occurs following either transfusion with the RH negative incompatible blood, or more commonly with the birth of an RH positive baby to an RH negative mother. So in the mother, right, the mother is RH negative, which means there are not any RH antigens on the mother's blood. And we do not have any preformed antibodies against the Rh antigen. Okay, so it's just the body in an Rh person, that body has never seen or heard of, for example, the Rh antigen at all. The only time that then we form a problem with the Rh protein or Rh antigen is when we've had sensitization, which is if somebody was transfused with Rh positive blood, then the body's going to say, nope, nope, that's not self. We've never seen that. We don't have that in the body. We're going to form antibodies against that. So that also happens with the birth of an Rh positive baby to an Rh negative mother. So problems are rare in the first pregnancy because a baby's blood rarely crosses the placenta. So we're going to talk more about the placenta and how blood flow works at the end of the semester. But the placenta is the organ of gas and nutrient exchange between the baby and the mother. So there is not a lot of crossing of blood at that time. However, during birth or immediately after birth, the Rh negative mother can be exposed to the baby's blood cells, the Rh positive cells, and then the body will start creating those antibodies to it. This happens about 13 to 14% of pregnancies. So after exposure, the mother's immune system then is going to generate these anti-Rh antibodies. So it's saying, this is not our blood, we need to form antibodies against an Rh positive blood. If the mother then should conceive another Rh positive baby, then those Rh antibodies that she has produced then will or can cross the placenta into the fetal bloodstream and destroy the fetal red blood cells. So this condition is known as hemolytic disease of the newborn, or HDN, or erythroblastosis fetalis, so breaking down of the fetus's red blood cells. This could cause anemia when it's a mild case because of the agglutination, and the hemolysis can be so severe that sometimes the fetus can die in the womb or shortly after birth because the mother's antibodies have just attacked the blood cells. So here is that in picture form. So we have the placenta here, and then our placenta arterial, which is the maternal, placental vein, venule, maternal, and then the maternal blood pool. And then we have the embryonic chorion, which is right in here, right, you can see that, which isolates the fetal blood from the maternal pool. And then here's our infant's umbilical cord, which has the artery and the vein in it. So they don't cross, they're separate. You can see the separation there. So in the first exposure, we have the birth of the Rh positive infant. Then we have during birth, they leak into the maternal blood, so we have this placenta is kind of being ripped from the mother in the process, and in that process we can have exposure to this Rh positive cell, and then that leaks into the blood after the breakage, and then 2 maternal B cells are activated by the Rh antigen and produce large amounts of these Rh or anti-Rh antibodies here that are going to lyse those cells and have agglutination. So at first, not a problem. Right now we've just got these antibodies, but if the mother then gives birth to or becomes pregnant with another Rh positive fetus, then the body already has these Rh antibodies in the mother's blood here. We have these anti-Rh antibodies here in the blood, and then they can cross over into the fetal bloodstream and start breaking down the fetus's blood. So a drug known as RhoGAM, short for Rh immunoglobulin, RhoGAM there, can temporarily prevent the development of these antibodies. So if a mother is Rh negative and is pregnant with an Rh positive baby, then this RhoGAM can be given. And then this RhoGAM antibodies are going to destroy any of the fetal Rh positive erythrocytes that may cross that barrier. So shortly before birth, during birth, this can be given. See here, RhoGAM is normally administered to Rh negative mothers during weeks 26 to 28 of pregnancy, and within 72 hours following birth. So if we break those things down, the body doesn't have a chance to make those anti-RH antibodies, and then an additional pregnancy with an Rh positive fetus then may not lead to the HDN, the hemolytic death of the newborn. All right, so, and this has been really positive here. It says since the introduction of RhoGAM, the incidence has dropped to about 0.1% in the United States, where we see this death of the fetus or the newborn, which is pretty fantastic. Determining ABO blood types. So we're going to talk just a little bit about determining the blood types based on these different blood groups. So clinicians are able to determine a patient's blood type quickly and easily using these prepared antibodies. Okay, so an unknown blood sample is allocated into separate wells. You can kind of see this down here as well. So there are these wells here, and then the blood is separated into the wells. Into one well, a small amount of anti-A antibody is added, and to another small amount of anti-B antibody. If the antigen is present, the antibodies will cause visible agglutination, so that clumping of the cells. And then the blood should also be tested for the Rh antibodies, or as is mentioned, or as is shown here, D. All right, so you can see here, the blood is put in here. We had anti-A in this one, anti-B in this one, and anti-D in this one, or the Rh factor. So these are commercially prepared antibodies. So the card contains 3 reaction sites or wells. One's coated with an anti-A antibody there, one with the anti-B antibody, one with the anti-D antibody. It tests the presence of the Rh factor. So mixing a drop of blood and saline into each of the wells enables the blood to interact with it. So the agglutination of the red blood cells in a given site indicates a positive identification of the blood antigens. So in this case, A and the Rh antigens for blood type A positive. Okay, so in this case, we add the anti-A, and then it clumps up, which means that there are A antigens on the blood cells in this blood because the antibodies are reacting with it. So if we add anti-A, that means it has A antigens. We add anti-B, if it clumped up, then there would be B antigens. It did not clump up. You can see the difference here. Here's clumping, and then here's not clumping. So there's no B antigens on the blood. Anti-D, so we add the anti-RH factor. If it clumps up, then we have the Rh factor in there because it's agglutinating and it is clumping. So in this case, we have an A positive blood type. All right, so ABO transfusion protocols. So we'll talk a moment about transfusion reactions. In order to avoid them, of course, we want to only match up blood types. So we want to give type B plus to a type B plus person. So type B plus donor to a B plus person. That said, in emergency situations, when there's acute hemorrhage threatens the patient's life, so we've got a massive amount of blood loss, there may not be time, to sit there and do blood typing to make sure that we identify the very specifics. So in this case, we look to something called the universal donor. An individual with type O minus blood may be transfused. So blood type O minus, remember the donor blood, if it's O minus, has no antigens on it here. Recall that type O erythrocytes do not display any A or B antigens. Thus, anti-A or anti-B antibodies that might be circulating in the patient's blood plasma will not encounter any erythrocyte surface antigens on the donated blood and therefore will not be provoked into a response. All right, so the donor blood has no antigens, no anti-A, no anti-B, and so it will not cause a response. So when there's no time for blood matching, we can go that route. One problem with this designation of the universal donor is if the O minus individual has had prior exposure to the Rh antigen. So there might be some Rh antibodies in the donated blood. And so if that's given to somebody that is Rh positive, then there could be some agglutination there. Also, introducing type O blood into an individual with type A, B, or AB blood will introduce antibodies against both A and B antigens, which are always circulating in the type O blood plasma. This may cause problems for the recipient, but because the amount of blood that's given to a person is much lower than the amount of blood the person has, then that little bit of agglutination isn't actually going to cause that much of a problem. It's more important to get the blood cells in there. So rather than being concerned with the anti-B and anti-A antibodies that are in the plasma, they're more concerned about making sure that you get the O blood that doesn't have any A or B on it into the person so that it gets some oxygen flow. The Rh factor also plays a role. Rh negative individuals, again, receiving blood have had exposure to the Rh antigen. The antibodies for this antigen may be present, and then we can have some agglutination. But again, remember, when there is transfusion, the amount of blood that's being transfused is so much lower that it's more important to get the blood cells in, and then if there is some agglutination, then that can be it's very small compared to the important process of getting the blood cells in the person. So we have the universal donor, which is O negative blood, and then we have the universal recipient. So universal recipient is AB positive. So this person can theoretically receive any type of blood because the patient's own blood, having both A and B antigens on the erythrocyte surface, does not produce any anti-A or anti-B antibodies. So it won't attack either A, it won't attack B, it won't attack AB, and it won't attack O because it doesn't have any of those. In addition, the Rh plus patient can receive both Rh positive and Rh negative blood, right? Because if it has Rh positive already, then it will not have the anti-D, anti-Rh antibodies in the blood. However, keep in mind that the donor's blood will contain circulating antibodies again with positive, negative, or with possible negative complications. So again, if you give them A blood, right, if you give an AB positive person A blood, it will have anti-B antigens in it, which will then attack the own person's AB blood. However, again, it's much lower. It's such a small amount that that won't be an issue most times. At the scene of multiple vehicle accidents, military engagements, other things, victims may suffer simultaneously from acute hemorrhage, yet type O blood may not be immediately available. So in those circumstances, they try to at least place some of the blood volume that's been lost. They do this by intravenous administration of saline solution that at least provides fluids and electrolytes that are similar to normal blood plasma. And so research is ongoing to develop safe and effective artificial blood that would then be able to be administered, so we wouldn't have these shortages in blood. All right, so now we can look at this chart again, now that we've talked about the blood types here, or the compatible blood types. So we have blood type A. Remember that it has the A antigens on the surface. It has anti-B antigens floating around. So antigens in the red blood cell, A antigen, the circle ones. Blood types compatible in emergency, A and O. Right, so we can put A blood in because it already is A blood, and then remember O is the universal donor. It doesn't have any of those things, so it would not be attacked by these anti-B antibodies. Same thing with B. We have the B antigens on the surface. Anti-A is floating around antibodies, so you can give B and O, right? B because it is B, and O again because there aren't any of the antigens on the surface of the O blood. Type AB has both A and B antigens on the surface, A and B antigens. There aren't any antibodies in the plasma, which makes it a universal recipient. It can have both A blood, B blood, AB blood, or O blood because there's nothing in here that's going to attack. So here, AB, AB, and O. And then here we have type O blood, which doesn't have any antigens on the surface. It has both anti-A and anti-B antibodies in it. It does not have any antigens on the surface, and that makes it the universal donor. And the only blood that a person that has O can have is O, because if we put A in there, then our anti-A would attack it. If we put B in there, the anti-B would attack it. So O gets O. All right. So that is the end of our blood chapter. Down here there are some key terms. These would be really good to look through. Make sure you understand the definitions of these terms. We went through many of them in the lectures, so you should be familiar with these. This would be a good spot to study. And then if you scroll through this, there is a chapter review going through and kind of summarizing things, which I think is also really helpful, just as a quick kind of review. And then there are some interactive link questions at the end of these chapters. You can click on here and kind of go through some things, explore different things. And then there are review questions, and I think that it's important that you go through and work out the review questions so that you can solidify your understanding in these different things. There are different types of review questions. There's multiple choice. There are critical thinking questions. Sometimes there's fill-in-the-blank questions, short answer questions. So even if you don't necessarily write these answers down, I think it's important to go through and make sure that you understand these things. All right, so the end of chapter 18. The next chapter we'll be moving into is the cardiovascular system, chapter the heart.